Hi, I'm Dr. Jared Gardner. I'm here today with my awesome dermatology residents and Dermpath fellows, and we're going to look at some neural and assorted other cases together. So the residents and fellows have had a chance to preview these, and now we're going to talk about them. Okay, so who wants to take this as case number one?
I can take the first one. So it looks like we have a deep dermal nodule. Everything's very pink, and when you go in on higher magnification, the cells are kind of S-shaped or comma-shaped, and that makes you think of a neurofibroma.
Good, I like that. S and comma shaped. Some people say wavy. I don't really love wavy because, like, if it's really, really wavy, it's usually fibroblastic. But the neural cells are kind of gently wavy, right? And I like that point that you made about, let's see if we can get it in focus here. S or comma shaped. The high power on this scan is not quite crisp, but I like that point. And my mentor Mark Edgar, I like what he said. He said that so these are Schwann cells. Schwann cells make that kind of S or comma shape. Sometimes they're kind of pointed on one end and blunt on the other, like a sesame seed. You know, those little seeds that are on top of hamburger buns. Yeah. So he said though that what he thinks of is that if you take the top of a can of Coke or something, and when you pop it open, when the tab comes off, it's kind of bent in the middle, right? Like because you popped it and popped the can of Coke open. And I love that. I think that actually is exactly what it's like. It's like you just like popped it right down in the middle with your thumb to open the can of Coke, and this is the shape that the tab on the top of a can. Hopefully Coke doesn't like sue me for mentioning their product in this video. Well, I guess I'll know that I've made it if that happens. So in any case, other neural things will have Schwann cells too. So what kind of other clue makes this good for a neurofibroma as opposed to another neural lesion? Anyone?
You may also see mast cells.
Yeah, that's good. Scattered mast cells. It's kind of hard to pick them out in this, but they're usually there scattered about. And that's because in the background, see how that's probably a mast cell right there. See how in between the Schwann cells, what do we have? We have this loose kind of disorganized little shreds of collagen. And those are classically called like the shredded carrot look, like if you shred up carrots to put on a salad. I don't usually put carrots like that on my salads, but I do shred carrots for other things sometimes when I'm cooking. And, sometimes you get the shredded carrot look. I think that's actually better for like big, deep neurofibromas, like big plexiform ones. They often have more prominent collagen. But what you do get is this fine little threads of collagen, and there's white or pale blue space between them. And usually what's in that space is ground substance, including some myxoid, kind of hyaluronic acid and myxoid ground substance. So that space, that like paleness, comes from the extra kind of goo that's in between the collagen. You don't have solid collagen. You have lots of white and pale space in between the collagen. And the collagen bundles, the little shreds, and the Schwann cells. And also there's going to be some fibroblasts, some perineurial cells, and I can't tell them apart on H&E, but with immunostains you can see that there's different components of cells here. Those all kind of haphazardly mingled together is what makes neurofibroma. And sometimes it's kind of loosely arranged in the dermis like this. You can also find extra little nerve twigs in it sometimes, little tiny nerve bundles. I can't remember if they were good in this one. I looked through these quickly yesterday, but in any case, so that kind of helps me. And so the thing is people I think in the past have called this bubblegum pink. And I was like, I think of bubblegum, growing up in the 80s and 90s as like bubble yum. Okay, it's the second trademark I'm mentioning here, which is like, bright neon pink. But this is like the old school nasty, like Bazooka Joe bubblegum. Third trademark. I'm going to have to like start a list here. In any case, it's that real pale pink, nasty. I don't like it at all. I think it's gross. But the traditional bubblegum, which is really pale, okay? So if that works for you, fine. But I do like the point that the collagen in a neurofibroma and the color of a neurofibroma is a different pink than the background. Let's look at low power. You can really see it. Look at once it focuses, here we go. Pale pink here, as opposed to the much brighter and more vivid pink of the dense reticular dermal collagen bundles. The collagen itself is actually the same color. The difference is here the collagen is more dense, and here the collagen is all spaced out by that myxoidy kind of background. So other things, fibroblastic things like spindle cell lipomas and stuff like that, that have spindle cells, collagen, and a little bit of myxoid background can look quite similar to neurofibroma. And you can also see this. This is, I guess you could, when you see a lot of this, you can call it diffuse neurofibroma, but you can see kind of what looks like infiltration of the fat, where the neurofibroma kind of oozes down and entraps fat, adnexal structures, and it can, diffuse neurofibromas can, particularly in neurofibromatosis patients, can be real extensive and go way down into the subcutis and look very infiltrative and aggressive, but they don't actually grow in an aggressive fashion. They're benign. Although with patients who have NF1, they can be very disfiguring, unfortunately, and problematic in that way. See, look, you got entrapment here. So this area kind of fits for diffuse neurofibroma. And I think right here, here's kind of a nerve bundle. And sometimes the individual nerve bundles will have, look like they're packed full of what looks like neurofibroma. So the neurofibroma can ooze into individual nerve twigs. Okay, well, we covered a lot in that one, but I think that's a pretty fundamental concept when thinking about neural things to really understand the heart of like a basic neurofibroma. Okay, very good. Case number 2. Who wants this one?
I can take it.
Okay.
So we can see that in a dermis there's a very, very blue nodule.
Mm-hmm.
So when we zoom in, you can see that it's composed of these very dark blue, very small cells. There's also, I note, a lot of kind of like blood extravasation, so it's like very vascular.
Good point.
And so each cell, if you look at it, has very little cytoplasm, but more of a nucleus that is kind of smudgy looking.
Okay. Yeah, right here you can really see that smudgy nuclear chromatin. Good.
So this is, and there's like mitoses and atypias is definitely a bad one, a malignant. So this is a small blue cell tumor,
Yep.
And there's a differential for it. We usually think of mnemonic lemons.
Okay.
So L for lymphoma, E for Ewing sarcoma, M for Merkel cell and melanoma, O is oat cell tumor, and N is neuroblastoma. And I think there's also a small cell endocrine tumor.
Yeah, and actually oat cell is like a super old school name that we don't use anymore, but it works well for your mnemonic, so which is basically now called small cell lung cancer, small cell carcinoma of the lung, and small cell, which is a type of neuroendocrine carcinoma. Small cell neuroendocrine carcinoma of the lung used to be called oat cell, but that type of carcinoma can occur at all sorts of different body sites. And this is Merkel cell. And Merkel cell, even though it arises from different pathways, it seems, than small cell lung cancer, is otherwise quite similar morphologically, looks very much, essentially to my eye, identical to small cell carcinoma of the lung. But it does have different immunostains and does seem to arise from different pathways. Some of these probably arise from ultraviolet light damage, and others actually arise through a Merkel cell carcinoma polyoma virus, which seems to play a role in the development of at least some of these. Like you said, it's a sheet of round blue cells. It has lots of mitoses. Like here, even though the scan is not quite in focus there, the mitotic rate in like a bad melanoma would be like, oftentimes I'll see 5 to 10 mitoses in a millimeter squared, which is, on my microscope, that's 3.5 high power 40x fields. It varies from scope to scope. Merkel cell carcinomas, their mitotic rate is usually closer to 100 or 150. Not always, but often in the over 100 range in that same area. So they're like 10 times more mitotically active than the average melanoma. And I'm talking about bad melanomas, like big, huge ones. Oftentimes, I mean, it's very rare for me to see a melanoma with more than like 20 or 30. That's really, really crazy. But these are very mitotically active. If you do a Ki67, which I don't think you need to, they'll be like 99% of the cells will stay in there, all in the cell cycle. And the neuroendocrine chromatin pattern can be variable. Some people describe it as salt and pepper. If you like that, fine. But because it has this kind of speckled light and dark appearance, but I like this case right here is nice because it shows sometimes you get that speckly pattern, but other times it's more like very smudgy or fine and dusty is kind of a word I like. And like you said, the cells are all made of nucleus with very little cytoplasm. I mean, there's a little bit there, but that's why it looks so blue. All of the round blue cell things are round blue cell because they have a bunch of nuclei packed together with minimal cytoplasm. So here you could think a bit of lymphoma, Ewing's, a lot of stuff. It's a little bit uglier than Ewing's. Ewing's is a translocation sarcoma and usually has very uniform nuclei. It's very rare in the skin, but it does happen sometimes. I've seen several cases. So it's good to keep in mind. But the thing that can help you here is if you look around in a Merkel for a while, usually you'll begin to find areas of nesting because these are carcinomas. So they're made of epithelial cells, and epithelial cells, kind of like melanocytes, they like to stick to each other, right? And so they make nests and kind of clump and cluster together. And so this clustering or clumping together, even without immunostains, that's a really useful clue that you're probably dealing with a carcinoma in this case, or melanomas can do that too. And there are melanomas occasionally that can have small round blue appearance, although I would say that a truly round blue one like this is quite unusual in my experience. I've seen lots of melanomas, very rare to see one that is like that perfectly mimics a Merkel, but it can happen. The other things about Merkel to know, so if you get one immunostain, which immunostain would you pick?
Probably CK20.
Yes, that would be my vote also, because I already know looking at this is almost certainly going to be neuroendocrine just by the appearance. CK20 is helpful because it is almost always positive in Merkel cell and rarely positive in small cell carcinoma of the lung. And also, it's pretty unusual for small cell carcinoma of the lung to present as a primary skin metastasis without a patient having a known diagnosis already, but I have actually seen a couple times. So usually what I do is if I think it looks morphologically perfect for Merkel, I'll do a CK20, and I used to in the past just do that. I've started now just including a TTF1, which is a marker for lung carcinomas. Some lung carcinomas like adenocarcinoma and small cell lung cancer are usually TTF1 positive. So I do that, and if it's CK20 positive, often with this little perinuclear dot pattern, and it's negative for TTF1, then I feel comfortable calling it Merkel cell carcinoma. Occasionally, TTF1 can be positive in Merkel, and in that case, I tell them, well, I can't totally rule out a MET from the lung. Please do a PET CT or other imaging and check the lung just to make sure before they proceed with definitive treatment. Okay, very good. So that's Merkel cell carcinoma. And this one I looked around that I didn't see lymphovascular invasion, but it's usually present. And my former partner, Sarah Shalin, used to always say, if you don't find lymphovascular invasion in a Merkel cell carcinoma, go back and look again because it's usually there. Although that said, I do occasionally see ones that don't have it on the original biopsy. And to my knowledge, it doesn't really change how they manage the patient. These patients, I think routinely, at least currently, to my understanding, get wide local excision and sentinel lymph node is the general standard treatment for patients who don't have distant Mets. Okay, good job. So that's my approach, and you can do neuroendocrine markers and other things, but usually I start with just CK20 and TTF. If those don't stain the way I expect, then I'll expand my panel to rule out melanoma, lymphoma, leukemia, other things in the differential. Okay, good work. Case 3. Well, I'm going to have to speed up and stop talking so much. I'm sorry.
I can do this one. So this one has really low power. It's not very well circumscribed.
Ah, that's good. So you glean an important pearl from low power here. You see a lesion here in the dermis, and it really is not circumscribed, right? It kind of trickles in at the edges. That's really helpful clue from low power for this tumor.
Yeah, then at higher power, I thought this one was a little bit tough actually.
Okay.
So the cytoplasm is kind of foamy from this power, but in closer, it's like foamy versus granular. I don't really know how to reliably distinguish between those two. So given the chapter, I started to think about like granular cell tumor.
Good.
But then there are a couple other features of granular cell tumor that I look for. The pustular ovoid bodies of Milan, which maybe I was just looking in all the wrong sections. I didn't feel like I could find great ones here.
It's okay. You don't have to. I mean, they're often there, but I feel like this at low power, I'm already thinking granular cell tumor instantly because it's got a certain pink color. This is distinct kind of pink color. It usually has pinkish gray almost. And then it trickles between collagen at the edges, almost always. It's very rare to see. I mean, I don't think I've ever seen a granular cell tumor that is like really smooth circumscribed borders. This type of granular cell tumor. There is a different non-neural, unrelated entity that is different. But for the true neural granular cell tumors like we're looking at here, they always trickle like this. And they have that color of cytoplasm, and the cells merge together and form this kind of syncytium. See, you can't see where one cell ends and the other begins. It's like they all share the same cytoplasm, and they form these long kind of trabeculae, these like elongated nests that kind of ooze and push in between the collagen bundles. But it's not really like infiltrating. I mean, it looks kind of like it is, but the dermis doesn't seem bothered at all, right? There's no reactive change. The collagen bundles are like, oh, hey, granular cell tumor, what's up? How's it going? Have a good day. Just pass on through. You see what I'm saying? They just like are totally fine with it. It's like the granular cell tumor is totally at home here, just hanging out with the collagen in the dermis. And I would say that's typical, although occasionally I see inflammation and reactive kind of changes around them. Your point is well taken about the telling granular apart from foamy can be hard, and also telling granular apart from oncocytic. That's even harder. Oncocytic cells are pink like this, but a little bit less individual dots in the cytoplasm, and they're filled with mitochondria. And granular cell tumor, the cytoplasm is filled with phagolysosomes, okay? And so that's what gives it this grainy kind of look. It is harder to see those very subtle differences in the texture of cytoplasm on a scanned slide if it's not this scan is not. All of these slides are not. I think they were scanned some years ago, and the quality then was not quite as good as it is now. So it's not as crisp. It's easier to see under a microscope. But normally the thing that helps me with foamy is these little white spaces probably made you think of foamy a little bit. But the vacuoles, the little white vacuoles in foamy cells are usually lipid filled, and so they're perfectly round little bubbles, and they often push in and indent the nucleus like you'd see in, say, a sebocyte or a lipoblast. So that's, to me, the difference is if I'm thinking if something's foamy, try to look and see if you can see nuclear indentation. We can't really tell here again because of the scan quality. So that is a little bit of the limitation here on this particular slide. But yeah, granular cell tumor, this kind of oozing syncytial cords of tumor pushing between collagen. They have these round nuclei with little dot-like nucleoli usually. The pustula ovoid bodies, I have been looking around and have not seen a real good one. But they're basically little round blobs of this kind of cytoplasm. And if you find one, great, that's cool. But you don't need it to make the diagnosis. And immunostains, anyone know what could you stain this with? Classically, there's a few stains. You don't usually need to, but if you wanted to.
S100,
yeah.
CD68.
Very good. S100 because it is a neural tumor, and CD68 because CD68 we think of as a macrophage marker, or histiocyte marker, but it actually is not. It's a marker of phagolysosomes, and so any cell with a bunch of phagolysosomes, then it's going to stain with CD68, and these cells are packed full of phagolysosomes. And look at this. This is important. This used to be a nerve. And this nerve is overrun by tumor. Well, that's usually a scary thing. But in granular cell tumor, that's actually seen in like almost 90% of granular cell tumors is perineural or intraneural involvement. I don't say invasion. And that's because they're neural tumors. So, of course, they're going to involve nerves. So that's what's going on there. So I don't even mention that in my report because it is not a worrisome finding. So nice example of granular cell tumor, an unusual form of nerve sheath tumor. Case number 4. No takers?
I can do this one.
Yeah, good. Give it a go. I'll edit it out if you're wrong. How about that? And if you're right, you'll look like amazing. So, because it's kind of an unusual and rare bird here.
Yeah, I spent a little bit of time on this one. Kind of a slightly spindled, but like, I don't know, in my mind, I just describe them as sort of plump spindled.
Good. That's great. I like that. Yes.
Cells within a really kind of a collagenous stroma to a certain extent. I thought there was some collagen.
Oh, yeah. A lot of pink collagen here. Yes.
Yeah. It has a somewhat world architecture. Is well circumscribed. My first thought, just because I hadn't reviewed neural in a while, was like PN, but it's not well divided into fascicles. So.
Good, excellent point. Yes.
Yeah, and so Perineurioma is what I came up with.
Nice, you nailed it. That's exactly. This is a beautiful example of a perineurioma. And perineuriomas have a neural look, but they're actually not made of Schwann cells, so they'll be S100 negative, although there are some hybrid things that have perineurial and neural combined together. And so if you see something that looks kind of neural and swirly, but is S100 negative or SOX10 negative, then right away you should think of perineurioma. You can also think of Dermatofibrosarcoma protuberans, because they also look neural and tend to be whirly and swirly. So the swirling or whirling is kind of the word that is the buzzword for for perineurioma is very dramatic in perineurioma because perineurial cells, they're like the peripheral nervous system equivalent of meningothelial cells. Their job is to wrap peripheral nerves, right? And to form the perineurium around outside of a peripheral nerve. And so when perineurial tumors develop, they do that same wrapping, whirling, swirling motion, often around little tiny blood vessels in the midst of the tumor. They often kind of swirl around that. Sometimes it's harder to see that the whirling, it can be really nice. This one's pretty good, but sometimes it can actually be quite vague and you have to like hallucinate a little bit. And I liked your point about this looks spindled, but also some of the cells look plump. They look oval to round. And that's because my understanding of perineurial cells is that they're kind of like flat, like a plate, like a dinner plate, maybe like an oval shaped dinner plate. So if you turn it one way, so you're looking at them on edge, you know, like if you put your hand up straight in front of you, it looks like a spindle cell. But if you flip it 90 degrees and look at your palm, then all of a sudden you're seeing something that's oval shaped. So the plane of sectioning here is what's causing some of them to look really thin and skinny and others to look more oval. And I would personally classify this as a sclerosing perineurioma, although the subtype is not really important because it's very dense collagen in this case, and also it's on an acral surface, which is a common place for the sclerosing type of perineurioma to develop. And sometimes sclerosing perineuriomas in particular can get much more of a rounded cell and can almost make like little cords and chains of rounded cells. But very nice swirling here. And so does anyone know what markers could you use to support a diagnosis of perineurioma if you want? There's three main ones that I like to use, mainly because none of them work perfectly, and they're kind of finicky, I feel like.
Like EMA, GLUT1.
Yes, very good. And kind of a newer one is Claudin-1. So EMA, GLUT1, and Claudin-1. So here's an example. Nicely, we have a scan of EMA, and wow, it's amazing. I promise you, it does not usually work this good in my hands, at least. I feel like EMA is often kind of focal and weak and finicky to get to work on perineurioma and spindle cell tumors. But look at how much it highlights that swirliness. And these can sometimes express CD34, so that could cause you some angst and concern about DFSP, but usually you're not going to see infiltration of the fat in these. Like this is a very nice, small, circumscribed thing, so I wouldn't, in this case, have been worried about DFSP really, but it really highlights that whirling. And the cracks in the collagen here is what, like you said, made palisated encapsulated neuroma come to mind. But as you perfectly pointed out, there's not like nice fascicle formation here like you would expect, which is the kind of the hallmark of palisated encapsulated neuroma. And let me show you over here, just so you can see. This is what EMA does on regular nerves. These are regular nerves in the background. In a second, there we go. It's little tiny nerves, and the EMA stands beautifully around the perineurium. Very nice. So that's a beautiful example of perineurioma, benign and beautiful. Really cool and relatively rare tumor. And I have a whole video on perineurioma if you need to see some additional examples, and it's on my YouTube channel. I'll put a link down below. Okay, case number, I think this is now 5, right?
I can do this. So you have a nice large specimen.
Okay.
Going deeper, it looks a little bit like there's like scar tissue or fibrous tissue.
Absolutely. You can even see from low power, there's a disruption in the dermis and the subcutis here, and there's a band of very dense collagen that's kind of irregular down here. So even from low power, you can say, why is there extra collagen here that looks different from the rest of the skin? So that's really a useful clue, even from low power, that you're probably dealing with scar. And here the scar's down. Look, we're down in the skeletal muscle. And all of a sudden, the skeletal muscle is all tangled up and messed up and replaced by collagen and something else. Sorry, I interrupted.
So looking closer, you see some nerve cells, neural cells, like neural bundles right there. So a traumatic neuroma where it's because there's scar tissue and neural.
Perfect. Yes, nerve bundles of multiple different sizes all packed together into a disorganized nodule within a background of scar. That's what you want to see for a traumatic neuroma. The idea is that a nerve, probably kind of a larger nerve, got cut during surgery or some other trauma. You can see these. I've seen them really nicely at like amputation sites where what's happening is the big nerve is trying to regrow and reconnect. It thinks the other end of the nerve is still there. So it's sending out all these little feeler nerve bundles, and instead they're hitting scar tissue and dead end and kind of curling and swirling around each other and making all these tiny little large, medium, and small size nerve bundles. And they're all tangled up here. It's kind of, you can kind of see nicely. This is kind of a pretty picture. There's skeletal muscle, there's background scar, and then there's nerve bundles of all different size. And one trick to recognize nerve bundles, if you see little spindle cells running in a little fascicle that are pale pink, see how pale they are compared to the muscle or the collagen? They're much paler because just like neurofibroma, there tends to be some background, slight bit of myxoid substance. Sometimes you can actually see myxoid in the nerve or around the nerve, but look at this. There's often this little space around the outside of the nerve, and then see that cell right there? That's a perineurial cell. So that's the perineurium, and you often have this little space that divides the nerve bundle itself from the little perineurial sheath, the perineurium around the outside. And I find that actually quite helpful to find that little space there, often with a little bit of blue mucin or myxoid substance. To find that can actually really help me, like when I'm looking at a case trying to decide if there's perineural invasion somewhere. This feature holds true for a lot of different nerves. So it can help me to tell, oh, that's a nerve, not a piece of smooth muscle or something else. Because sometimes it can be a little challenging. Because look, those aren't wavy, are they? Not a bit. Sometimes nerves can be a little wavy, but like I said earlier, not super wavy usually. And if the nerve's big enough, you can often see little axons with myelin around them. It's a little hard to visualize here, but nice example of a traumatic neuroma. Very good. All right, case 6. Any takers?
So this, there's something in the dermis kind of like trapping the fat a little bit with that Swiss cheese pattern from even like up far away. So a DFSP comes to mind.
Good.
Quickly.
Yeah, at low power, that should be the first thing on your list. There are other things that can do this. And like I pointed out just a little bit earlier, diffuse neurofibroma can infiltrate and really create a very similar appearance. So can fibrous hamartoma of infancy and some other things, spindle cell lipomas and others, that can all have bland spindle cells with a bit of sometimes a bit of mucinous kind of myxoidy background. Not a bunch here, but sometimes they do. And then intermingled adipocytes. So it's important to remember there are other things, but on a test, you see fat and spindle cells like this. First thing you should think of is, a dermal spindle cell process going way down in the fat and trapping little islands of fat stranded and wrapped around by tumor. Dermatofibrosarcoma protuberans should be top of your list. And when we go closer and look at the cytology, look, they look a little bit wavy to me, don't they? See, a little bit S-shaped. The fibroblasts can look really similar to Schwann cells sometimes. So fibroblastic tumors and neural tumors, I feel like that differential without immunostains, sometimes they can really have overlapping features. So it's always good to think of fibroblastic things alongside neural things. Like, look at that. If I just showed you this, you could absolutely think of a neurofibroma or a neural tumor. At least I would as a soft tissue pathologist. I would consider it. And so if you had to sort that out, you do an S100 or a SOX10, which is essentially always negative in DFSP, but of course positive in neurofibroma and neural tumors. Although I used to say never would you have S100, but I have now seen only one example of DFSP. It was a higher grade fibrosarcomatous DFSP that had patchy S100. And we confirmed with molecular that it truly was dermatofibrosarcoma protuberans. But that case was really shocking to me. But in general, if you have a doubt between DFSP and a neural tumor, don't do CD34, which will, of course, stain almost all DFSPs with occasional exceptions. But it will also stain the majority of neurofibromas because they have fibroblasts in the background that are CD34 positive. So CD34 will stain DFSP. And if it's negative, you should be real hesitant about DFSP, except for those fibrosarcomatous higher grade ones sometimes lose 34 expression. But 34 is a very sensitive but not a specific marker for dermatofibrosarcoma protuberans. And as we looked at the cells here, did you see any pleomorphism or atypia? Not really, right? These are translocation sarcomas. They have collagen 1A1, PDGFB gene rearrangements in the majority of cases. And now we've recognized that a small number of cases have been reported which have alternative fusions, usually involving PDGFD, not B, D as in dog, PDGFD. So I've now seen, I think, 2 cases of that, and there are about a dozen cases in the literature. So I'm starting to, if in an easy case like this is, to me, on H&E DFSP. If I wanted to do anything, I'd do an S100 and a CD34. S100 should be negative, 34 will be positive, and then I'd call it dermatofibrosarcoma protuberans, and the patient will go on to get either Mohs surgery or wide local excision. But I do take this diagnosis very seriously, even though the risk of metastasis is quite low. They are locally aggressive tumors that require big surgeries and often leave big scars and a lot of morbidity long term for these patients. And they can have a high tendency to recur if they're not cleared with a good margin. And I will point out something that will be frustrating to you. See this? Look at that beautiful collagen entrapment. Isn't that supposed to be a feature for dermatofibroma? Well, sometimes you see it in DFSPs. So it is a nice feature for DF, but it's not a nice feature to tell DF from DFSP because they both can do this. I think the fat trapping and the bland kind of almost neural look of the spindle cells are very good features to point to DFSP. To dermatofibroma, which I don't have an example to show you today, they're going to tend to have fat, plump cells, some scattered atypia, hemosiderin, little blood-filled spaces, foamy histiocytes, sometimes Teuton giant cells. All of those features are strong things to point towards dermatofibroma and away from DFSP. All right. So that's dermatofibrosarcoma. And let me show you, there's one feature that I didn't mention yet that's the buzzword, and that's storiform pattern, right? That whirling, swirling growth. So I do have a case pulled up here that I posted the virtual slide. I'll put this link down below. This is on Kiko. This is a huge DFSP. Sometimes they get quite large. I think this is from the scalp. And this one had some fibrosarcomatous areas. Look, they can get staghorn vessels similar to those so-called hemangioparasitic vessels. Commonly, you can see in big DFSPs, especially when they have fibrosarcomatous transformation. But why I wanted to show you this one is look at that. No fat trapping here, but that's about as good of a storiform pattern. That's the picture right there. Burn that into your mind. That is storiform. I can describe it with 1,000 words, or I can show you this picture. This picture is what storiform. That's like wow, that's the most storiform of all. It's kind of swirled, whirled, like palisades turned in a circle, stirred with a spoon. There's a bunch of cartwheeling, pinwheeling. The reason we have so many adjectives is because not a single one perfectly describes this amazing, very distinct pattern that I find very interesting and fascinating to look at. This is classic for DFSP, but some DFSPs don't have it. And also you can see whirling and swirling in a variety of other things. Perineuriomas, sometimes dermatofibromas can have swirled areas, not quite like this, but they can have some storiform pattern. So that's DFSP, dermatofibrosarcoma protuberans. Okay, case number 7.
I can take this one. So we see this kind of pink circumscribed nodule. You don't see any epidermis, so you know it's kind of deeper in the skin. And you can kind of see that it almost has that capsule, like it's encapsulated.
Mm-hmm.
So looking closer, I saw a lot of hemosiderin, and I thought I would look for, first thing that came to mind with a lot of hemosiderin, I thought about like a giant cell tumor of the tendon sheath. So I started to look for the osteoclasts, like giant cell osteoclasts, but I couldn't find them. But instead, like there are these very hypercellular areas, and they kind of look like the Verroque bodies to me.
Good.
And so then I started looking for, so that we would call it like Anthony A areas. And so the periphery, you can see a little bit looser, but still kind of hyalinized, and I didn't appreciate it to be super myxoid like I would expect areas. But that would be probably Anthony B areas, so this is good for Schwannoma.
Nice. And this is a little bit of a tricky Schwannoma, I think. You're right. The Anthony B is not very well developed at all here. And sometimes it's not. That's the thing about Schwannomas. They can have a wide range of features. Sometimes they can be very cellular. Sometimes they can be very hypocellular. You can have varying amounts of Anthony A cellular areas in Anthony B. Sometimes they have a lot of hyalinization. Sometimes they got a lot of blood. They have a lot of blood and hemosiderin. I actually find that a helpful feature. If I see hemorrhage, I think that's actually pretty good for Schwannomas. They often have that. And you were right to think of seeing hemosiderin to think about, could it be giant cell tumor of tendon sheath, because they often have hemosiderin. The biggest difference to me there is that this is quite spindled and arranged in fascicles, and the cells of giant cell tumor of tendon sheath usually are much more plump, fat histiocytes. I'll show you an example later. So they do have a different cytology, but that's kind of more of a subtlety that takes looking at some cases for a while to pick up on. But you can see sometimes in Schwannomas, they make nice fascicles. This is pretty fascicular to me, but there is palisading. So see, these cells are kind of lined up together, then there's a space where where there's fewer cells. Then these cells are lined up together into kind of a clump. So these are palisaded, but they're not like in the perfect dramatic rows like some schwannomas have. Sometimes in schwannomas, the palisading is striking. Like you could like, you know, very like linear. But other times it's more of this vague clumping of cells with areas of hypocellularity or kind of rarefaction of cellularity. Here's a better, look at that. That's a nice palisade there. And some schwannomas, unfortunately, do not have Verricae bodies at all. Like they really have very minimal palisading, and those can be quite challenging. So in those cases, you look for the capsule, you look for the loose kind of areas. You can look for changes in the vessel wall, which this one doesn't really have, but I'll show you one later that does. The other thing I did wonder about actually when I looked at this case is it almost looks like bundles with clefts around it. So I would certainly think of a palisaded encapsulated neuroma a little bit here. So because this one is down deeper and looks like it's in the subcutis and it's got a nice capsule around it, like a good capsule, which even the palisaded encapsulated neuroma sounds like it should have a capsule. It's not usually like the capsule like a schwannoma has. So I would vote for a schwannoma here, but it's one that has a little bit of an overlap to me with palisaded encapsulated neuroma because it's kind of got bundles with clefts. And in real life, it really doesn't matter. They're both benign nerve sheath tumors. And in fact, nerve sheath tumors sometimes have overlap, and I've occasionally called things benign peripheral nerve sheath tumor and said that, oh, it's got overlapping features between a couple different entities. So they don't always fit nicely into a box. But when you're learning them, it's good to pretend that they do, and that will give you hope. And then once you get into the real world, you realize, wow, this stuff's actually pretty challenging sometimes to make it all fit. Even for me, after almost a decade of doing this, I still run into ones where I'm like, this doesn't fit nicely into the rules that we make. Tumors don't read textbooks, right? They do whatever they want. So, oh, here's some pretty nice palisading. Look at that. And so a lot of times you'll see hyalinization, like real dense collagen around vessel walls, but this one doesn't show it. And you can also see scattered pleomorphism. That's a pretty common, well, here there's a little hyalinization around this vessel. Not great, but a little bit. There's a little hyalin and some hemosiderin. See, the vessel's been leaking blood. And I feel like the vessels in schwannomas tend to be kind of leaky. And so they get fibrin around them, dense collagen around them, blood, hemosiderin. I find those all helpful clues when you don't have other classic features. All right, so schwannoma, good job. It's good to see lots of different ones. And like I've told you guys before, schwannomas are usually in the subcutis or deeper. Pretty rare in my experience to see a truly dermal schwannoma. It happens, but it's rare. If you think it's a schwannoma and it's in the dermis, it's probably actually a palisaded encapsulated neuroma instead. Okay, good work. Case 8.
I can do this one. So this one from low power, you can see like very dark, kind of small round blue cell tumor in the dermis. And when you look closer, like the nuclei look kind of like smudgy, which is what I think of when I think of like a Merkel cell. I guess some people say like the salt and pepper kind of look.
Mm-hmm.
But I definitely want to stay and do a CK20 for this. But then above it, there was a little bit of change in the epidermis as well.
Oh, yes.
And you can get like intraepidermal Merkel cell, but like this looked like that kind of wind-blown, poorly maturing kind of look of Bowen's, which you can definitely have both of those.
Yes, perfect. Good job. You were not tricked. Yeah, here's like a little bit more normal epidermis for comparison, and then all of a sudden it turns into full thickness atypia with high mitoses. And you can see it's kind of goes around this acrosyringium sweat duct opening here. So yeah, this is a squamous cell carcinoma, situ Bowen's disease, if you like. And then here underneath it is Merkel cell. And in fact, we know that Merkel cell and squame tend to have a tendency to coexist sometimes. And people have debated over whether they're growing, rising together, or if the Merkel is actually diverging and differentiating into neuroendocrine and squamous differentiation lines, because sometimes it is in situ like this. Sometimes there's actually invasive squame right next to a Merkel. And you could just think, well, maybe it's coincidence. And that seems reasonable, right? But I have to tell you, I maybe have seen Merkel with a basal cell next door once or twice, whereas I see Merkel with squame next to it a couple times a year. So, and basal cells are very, very common. Why don't we see them growing together? There must be something here. And some studies have shown that Merkels that have squame with them are a bit different. In fact, when you see TTF1, the lung cancer marker, expressed in a Merkel, it's usually in Merkels that have squame with them. So they seem to have some different pathway, and there's something different going on about this group. And there have been people who have published on this much more extensively about the likely underpinnings of these diseases, which we don't have time to go into today. But like you said, this is Merkel cell carcinoma and squamous cell carcinoma in situ. When you see in situ malignancy over a Merkel, it is the majority of the time, I would say, it will be squamous cell carcinoma, not Merkel in situ. But Merkel in situ does happen. And so, but when I see that, it usually is more like little clusters of cells and some pagetoid spread. I don't think I've ever seen one that had full thickness atypia. I'm sure it could happen, but I feel like when you get full thickness atypia in the epidermis, that is a strong sign for squamous cell carcinoma. Even if there is some pagetoid spread, that favors squame rather than pagetes, rather than melanoma, rather than Merkel in situ. All those other things that can get in situ intraepidermal involvement do not tend to produce this wall-to-wall, sealing the floor, full thickness atypia like you see in squame in situ or Bowen's disease, whichever name you like. And there's another piece up here, I think, that once it focuses, really nice, right? I mean, no doubt about that. That is squamous cell carcinoma in situ. Classic. So great example of that. And it's good because, you know, if you're having a bad day and you had a small biopsy, you could think squame in situ with some inflammation underneath it. That would be treacherous, right? You could pay attention to the squame in situ and forget to look closer at this and realize, oh, that's not just lymphocyte inflammation. That's actually Merkel cell. That's a real treacherous thing on its small shave. So when you see clusters of blue cells, I always pay attention to them and look closer just to be sure you're not missing something else, because it's always possible to have two diagnoses. Once you get to one diagnosis on a slide, don't stop. Look at the rest of the slide. In fact, I try to, when I look at a slide, as my fellows and residents well know, if I see the obvious finding here, sometimes I stop at low power and I look out at the edges, because I know once I go closer here, I'm going to get focused on what's happening here, and I might forget to go back and check the outside. So when I see an obvious finding, I try to check the other normal looking areas around there first, then go focus on the obvious thing. But that way I don't miss some subtlety in the background. That works for my brain. Your brain might be different. Okay, good work. Case number 9. Oh, what a beauty.
I can do this. So this one has kind of like these myxoidy areas.
Mm-hmm.
And they're almost encapsulated within like a deeper circumscribed nodule.
Yeah, nodules within a nodule, right? Multiple small nodules packed into one bigger nodule. Good.
Exactly. And I don't know that there's too much else that looks like this. I don't know if there's a good differential, but
to me, there's no differential. This is one thing only. I don't know if that's right, but
okay. This it looks like a myxoid neurothekeoma.
yeah. So these in what we call them now is a nerve sheath myxoma, and that's to distinguish them from cellular neurothekeoma, which that's the only other thing I can really think of that looks like this sometimes, is cellular neurothekiomas have areas in them a lot of times that are myxoid, and sometimes those myxoid areas can look quite like this. So historically, people thought maybe they were related, and over time it's become clear that they are not related at all. Cellular neurothekeoma, despite the name, is not actually a neural tumor. Probably it's a histiocytic, fibrohistiocytic, whatever those are, a family of tumor. It's kind of unknown derivation, or fibrohistiocytic. It's not neural because it's negative for S100 and SOX10. Whereas nerve sheath myxomas are definitely nerve sheath tumors. They're S100 and SOX10 positive. So if you see, it's real easy to distinguish, but if you see something that has this area plus a cellular nodules, you're almost certainly dealing with a cellular neurothekeoma, not a true nerve sheath myxoma. But yeah, in the past, because of that confusion, these were called conventional or myxoid type neurothekeoma, but now we distinguish and call them nerve sheath myxoma instead of neurothekeoma to avoid that confusion. And if you want a more in-depth view, I have a whole video about those two entities and how to tell them apart and why the names are so confusing, because because people ask me this all the time, and I was like, I'm going to make a video to explain it. So it's on YouTube. I'll put a link to it down below if you're watching this online. And the one thing I'll point out, this case I recall well because this was actually my case, and I shared this with Dr. Ferringer, whose slide set this is, long ago through a recut exchange. And when I pulled this up reviewing the cases yesterday, I was like, hello, old friend, because it had such a distinct look, this particular case, and I recognized it immediately. And the reason that is really cool, let me find the area, I think it's right here, is this. This was a case where I learned something new, and those cases tend to stand out. Look at this. It's like a Verruquet body. It's lined up cells, a space, and more lined up cells. It's like this kind of curving, snake-like Verruquet body, and I went and did a literature search for, I thought maybe it's a Schwannoma, myxoid, palisaded schwannoma, multinodular. And what came up was a paper about nerve sheath myxoma, because it talked about how in the past some things that were thought to be myxoid variants of schwannoma probably fit into this name, nerve sheath myxoma. So I kind of think that these probably are maybe a closely related variant, a myxoidy variant that's related to schwannoma. I mean, it's a benign nerve sheath tumor, so whatever name you give it, whatever. But that's a very, very distinct and incredibly beautiful classic view of a benign dermal nerve sheath myxoma. Good job.
So this has a pink ball in the dermis with prominent places of blood vessels, it looks like, or blood.
Yeah, they're vessels, blood. Yep.
And a pink marble in the dermis with blood. I think you didn't think of like an Angioleiomyoma.
Yeah, perfect. This is a perfectly circumscribed, like you said, a pink marble. It's got prominent blood vessels of varying size. Sometimes it's one big one. Much more often, I think it's large and small ones, but they have thick walls, and the muscle, you can see their vessels because not only do they have blood, but they have a layer of endothelial cells. And the muscle comes straight off the vessel wall and just kind of merges out with all the muscle from all the other vessels and all packs together to make one solid mass of smooth muscle. So this is called an angioleiomyoma, or a leiomyoma vascular type is what I sometimes will give as an alternative name. And smooth muscle is pink and runs in bundles and has blunt-ended cigar-shaped nuclei and often has these little pale clear vacuoles, which represent glycogen vacuoles. And usually I would say that these are usually in the subcutis, but sometimes, like this one probably came from the subcutis, see, and just pushed up to the dermis. See, you can almost see like a little plane between it and the surrounding dermis. So it probably has pushed up into the dermis from the subcutis, because normally they're subcutaneous and they're often on the lower legs, more common in women, and they're usually painful. So a really classic example of angioleiomyoma. Good job. Okay, the next one is case 11.
I can take this one. So we have this, I don't know if it's a large punch biopsy or an excision.
Part of an excision.
Part of an excision. And you can see that it is all very pink, but like you pointed out previously, that the pink is a little bit different, maybe color pink. It's a little pale.
Yeah.
This one does have a little bit of hemosiderin deposition there. Yeah, but like if you look at the cells, again, they're the comma shape or little S-shaped cells in this kind of pink bubblegum stroma. So we could also maybe find some mast cells as well here.
Yeah.
This one is good for neurofibroma.
Yeah, very good. This is a neurofibroma, just like that other case. In fact, the cytology is much more easily visualized here. And this neurofibroma has a bunch of pigment. And in fact, these pigment, rather than being like inside macrophages or histiocytes like we would expect hemosiderin usually to be, look, it's actually individual elongated kind of dendritic branchy spindle cells. So this is actually melanin pigment. If we did a stain, this would be Fontana Masson positive and negative for iron stain. Sometimes it's hard to tell on H&E. I mean, you can often tell, but sometimes it's challenging. But yeah, so these are scattered melanin positive dendritic cells, basically melanocytes, scattered in the middle of a neurofibroma. So this is a pigmented neurofibroma, relatively uncommon variant of neurofibroma. The cases I've seen are usually big, diffuse neurofibromas, and not always, but many times these patients are NF1 patients. So they can be quite large, like big. I've seen them like 15, 20 centimeter plaques, like on the trunk. So they can be really big. So it's an unusual variation of neurofibroma. And otherwise, if you take the pigment away, it has all the features you'd expect in a neurofibroma: the comma-shaped, S-shaped cells, the kind of pale, slightly myxoid and collagen mixture in the background of between them, and mast cells. And this one is good because, okay, come on, focus. Look at that fat trapping. Really, I mean, if I gave you a picture of this, you could easily think, focus please, there we go. If you gave you a picture of this, you could easily think of DFSP, right? I mean, it's got fat trapping, very similar to what you would see in the dermatofibrosarcoma protuberans. And again, like I mentioned to you earlier, the cytologic features of neurofibroma and DFSP can be quite similar. So immunostains can help. And remember that DFSP sometimes has a pigmented variant too, called a Bednar tumor, where you have melanin positive cells in the background of a dermatofibrosarcoma protuberans. So this is one where you could do CD34 with a neural marker like S100 or SOX10, or you could just do a neural marker. And the thing about diffuse neurofibromas is often, not always, but often they have a special type of structure in them. And that's what we're seeing right here. Come on, focus up a little more. There we go. See these kind of little swirled little structures where you've got pink that are kind of wrapped, like little circles of pink wrapped around by some of the Schwann cells. So these are called Wagner-Meissner bodies because they resemble the Meissner corpuscles that you see in the papillary dermis on the finger. And you can see similar structures actually in neurotized benign nevi, but they are often found in diffuse neurofibroma. So that can be a helpful, oh, there's another one. Those are really nice there. See, there, I think of them almost as little palisades, like almost like tiny little Verrier bodies, but instead of in a linear configuration, kind of a circular or oval configuration. That's what they make me think of. So this is a nice pigmented diffuse neurofibroma. Okay. Case 12.
So this one, there's something going on in the upper dermis extending into the reticular dermis, and there's purple areas and light pink areas.
Oh, good. Yes. What do you suppose the light pink areas are made of?
Histiocytes?
Yeah, usually when you see pale pink or gray, that means there's a lot of cytoplasm, and oftentimes that's going to be a histiocytic process or something else that has abundant cytoplasm. So there's sheets of histiocytes, and then the dark blue areas are lymphocytes and plasma cells usually.
And I find this sometimes really hard to, the imperiopoiesis, I find it sometimes a little bit difficult to really identify. But I think there's a couple right there, right in focus, where there's the 3 nuclei merged into one cytoplasm.
Yes, good. Yes, imperiopoiesis is the buzzword. This is, of course, Rosai Dorfman disease, which was first described as a finding in lymph nodes, but also is now well recognized as being extranodal in some cases, and where it can occur in the soft tissue. So what you see is these big pale pink histiocytes. They have their nuclei look like this. This is actually really important in the real world to make the diagnosis, is recognizing not the imperiopoiesis, but the low power pink and blue look, the pale areas and dark areas. It's very characteristic. And then seeing these huge nuclei. The Rosai Dorfman histiocytes have these very big nuclei that have a very pale, clear looking chromatin and usually have punctate, kind of enlarged nucleoli. See the big nucleolus in the middle of these? That's a really characteristic, true Rosai Dorfman. I want to see that nuclear feature. And then what you'll see is, in fact, we're seeing tons of imperiopoiesis right here in front of us. It's just hard to recognize. Here's a good example. Look at that. There's like a little, maybe a lymphocyte or a red cell precursor. It's actually hard to tell, or a little squished neutrophil. Red or white blood cells in little tiny vacuoles inside the cytoplasm. Here's a neutrophil right there in the cytoplasm of a histiocyte. Here's a lymphocyte in a little vacuole. They're sitting inside vacuoles in the cytoplasm of these histiocytes. So it's a great picture to put in books, but in real life, this case actually has quite a good bit of, as I looked around in it, I found some pretty nice imperiopoiesis here. A lot of times it's quite hard to see, actually, I think. If you do an S100 stain, it will help make it stand out. S100 usually is strongly positive in the histiocytes of Rosai Dorfman disease, and it will help make those little vacuoles around the imperiopoiesis stand out. But basically, like everything we're looking at here is a sea of cytoplasm of these histiocytes, okay? So, and there, look, that's a nice one. There's imperiopoiesis there. Histiocyte nucleus, and there's a leukocyte, a white blood cell of some sort in a little vacuole. And the clusters of lymphocytes and plasma cells in the background, this case not as prominent as usual. And I would say that this, in my experience, is pretty uncommon to have dermal Rosai Dorfman. The majority of extranodal Rosai Dorfman I've seen have been in the subcutis, but occasionally it can be in the dermis also. And, you know, we often teach Rosai Dorfman alongside Langerhans histiocytosis because both are S100 positive. But the problem is that Langerhans doesn't really look anything like Rosai Dorfman. I don't think I've ever seen a case where I seriously considered both in my differential diagnosis. So that's a nice example. And I've got a whole video on that I'll put a link to down below. Great example here of Rosai Dorfman disease. 14.
I can take this one.
Okay.
So this one from scan sort of looks like the nerve sheath myxoma that we looked at earlier, with like the fiber strands and then these sort of purplish pinkish areas in between. But going into higher power, those island areas are very cellular, not mucinous as they were in the nerve sheath myxoma. So I think this one is cellular neurothekeoma.
Yeah, very good. Cellular neurothekeoma also has the little theques, the little nests, divided by dense collagen usually, but is composed of cellular, at least some of it needs to be composed of cellular areas of kind of histiocytoid-looking cells. But like I mentioned earlier, it's pretty common to have myxoid change. Sometimes can be abundant in these, but there should be at least some area that's obviously cellular. These, if we look at them, they're not loose configuration of spindle cells with a myxoid background. These are big, plump, fat histiocytic cells or histiocyte-like cells packed into nests. And this appearance actually, to me, is quite similar sometimes to nests of melanocytes. Kind of, I've seen cases that look quite a bit like Spitz nevus, like an intradermal Spitz. So I think if you see something that you think is an intradermal Spitz nevus with real nice prominent nesting, always keep cellular neurothekeoma in your differential. And that can be important occasionally because if you see a lot of atypia and mitotic activity in a spitzoid melanocytic lesion, then you start getting worried that maybe you're dealing with an atypical spitzoid tumor or a spitzoid melanoma, Spitz melanoma. But if you do a SOX10 or an S100 and it's negative, then that's pretty much out. What you're dealing with probably instead is a cellular neurothekeoma, and atypia and mitoses are pretty common in cellular neurothekeoma and do not seem to have any indication for malignant behavior. So they can look pretty scary sometimes. They can have really prominent pleomorphism and even occasionally atypical mitoses. And the nuclei have a kind of distinct look to me. They really have like this kind of nice, fine, pale chromatin. They have a very kind of histiocyte appearance. See, there's a mite right there, mitosis. There, see that pale nuclear chromatin? Very histiocytic looking, and that kind of washed out, cleared chromatin in the nucleus I find very helpful for this entity. And there are a variety of markers people have described, none of which are terribly specific. So to me, the main thing I do is if it looks good for cellular neurothekeoma, and then I do a melanocytic marker to rule out a melanocytic tumor, that, and you know, SOX10 or S100 is negative, then I feel comfortable making a diagnosis of cellular neurothekeoma. And there's a lot more to this entity. And again, I have a video about this and about nerve sheath myxoma. And if you want more details, you can go check those out. So these are benign, kind of a rare benign tumor in the skin, cellular neurothekeoma. Okay, 14.
We have a shaved biopsy of a papule, and it looks like we're on maybe like facial, head and neck area with sebaceous
Big
glands.
sebaceous glands, yeah.
And then, I mean, low power looks like a nevus to me.
Yeah.
Maybe
But
congenital features.
And at high power,
Still looks like a nevus.
Yeah. well, it is a
little
nevus.
Neurotized,
You're
I
you're
guess.
too good because you see this all the time. So this doesn't strike you as anything fancy. Yeah, it's a neurotized nevus, which I just signed this out as benign nevus. They often have a congenital pattern to me. They go deep down in the dermis and around adnexal structures, as Connie, one of our awesome Dermpath fellows, well knows. But they can cytologically closely resemble the appearance of neurofibroma, right? They have that very Schwannian look. So these are, if you like the type A, B, and C, these are type C melanocytes, the ones that are Schwann cell-like or neural and spindled. They often have adipocytic metaplasia in them, so there's fat up in them. And I think the other piece showed even better. Oh, look, a bonus. Trichostasis spinulosa. Like a little bird's nest with little eggs in it. These are all little tiny hair shafts from the same follicle all together. I've always been fascinated with this totally non-important Dermpath entity for some reason since I was a resident. I thought it was so cool. But look, you can get these little structures that look like the little world, round little circular things. They look like Wagner-Meissner bodies. So sometimes people call these tactoid bodies, or I think they're also known as meson bodies. But Masson has his name on quite a few things, so I think we've got to draw the line somewhere, okay? His contributions to pathology are already well recognized. But here's the thing. In a neurotized nevus, you can easily tell it apart from a neurofibroma because essentially always, if you go up to the top or the area under the epidermis, you're going to find some round, obvious nests of nevus cells. This area is folded, I'm sorry. So I feel like that's an easy way. If you think you have a neurotized nevus, if you look around, you will find some areas, even if they're focal, that look like round little clusters of nevus cells, and those usually tend to be right underneath the epidermis. Or you might even find some junctional nests. So yeah, neurotized nevus. If you want to call it that, cool. I just called it, I would say this is a benign melanocytic nevus, congenital pattern. That's what I would put on my my diagnostic line in my report. Good job. All right, why don't you take this one also, Connie? Because that last one was a softball. So let's give you this one.
So pixel site, pedunculated, and you could see, well, obviously acral site, and then you could already see from this tower, because my differential here is usually like acquired digital fibrokeratoma versus accessory digit.
Good. And how do you distinguish?
Nerves.
The nerves. Yeah, perfect. And exactly. You can see real nice bundles of nerves, and like I mentioned to you guys earlier, look, these are actually wavy. So sometimes you get wavy nerves, but they're kind of gently undulating wavy. But look at that myxoid in the background. Nerves tend to get myxoid around them. I feel like in acral sites you see that more, and also in irritated or inflamed nerves, nerves that are involved by tumor. All those times I tend to see more blue mucin or myxoid material that's in between the individual nerve bundles and separating it from the surrounding perineurium. But yeah, we got these big, thick nerve bundles, and occasionally I've even seen more well-developed accessory digits that had actual little bit of bone and cartilage in them. So the site, of course, is going to be the lateral to the pinky finger, right? The lateral hand just next to the base of the fifth digit, the pinky, and that's what you're going to see. The other things you could think of, if it were another site, you could think of a traumatic neuroma or something else. And if you took all the nerves away, like you said, acquired digital fibrokeratoma would look just like this, only it'd be full of just collagen with no nerve. Good work. So accessory or supernumerary digits. A sixth finger. Okay, who wants this one?
I feel like I should take this one.
Okay.
So we have this very round, well-circumscribed nodule deep in the dermis. Looks very pink, like a pink marble, another one. And you can see from the scans, so there are some areas of pigment. And it's kind of very golden brown and refractile, so probably hemosiderin.
Good, yep.
And then we have a couple of population of cells. So there's these very kind of plump, spindly cells, like fibroblasts. But there are also these multinucleated osteoclast-like giant cells.
Good.
So this is the giant cell tumor of the tendon sheath.
Very good. You get scattered giant cells, although occasionally there's no giant cells in these, and that can be really challenging because the actual tumor cells, we think, are these plump, fat histiocytes here. These histiocytoid cells that have abundant cytoplasm. Here's one that's like, looks like it's getting eaten by the giant cell. And here's another one. See, they have eccentric nuclei, kind of almost plasmacytoid shape or rhabdoid shape a little bit, if you like. Maybe plasmacytoid's better. But yeah, this kind of big nucleus pushed to the side, abundant pink cytoplasm. Those are the cells I want to see to make a diagnosis of giant cell tumor tendon sheath. They're fat, big, plump things. I don't mean adipocytic fat. I mean, you know, they're chubby, okay? And then, like you said, hemosiderin is often present, dense background collagen, and osteoclastic giant cells in varying amount, usually very sharply circumscribed, sometimes multinodular. This one's a little unusual in the fact that it's close to the skin. Usually these are down right on the tendon sheath, and I feel like it's relatively uncommon to see them sampled, you know, in a shave biopsy. So this one's kind of pushed up from down below, but more often they're deeper down. And one other feature that we can see that's really nice clue, and is often, not always present, is foam cells. Xanthomatous cells often around the periphery. These are foamy histiocytes commonly found in giant cell tumor of tendon sheath, which is also known as tenosynovial giant cell tumor, localized type, and I've got a whole video about that entity, and I'll put a link down below. Nicely done. Good work, Oksana. Okay. Next one, 17. Where are we?
I think it's the lip.
Yeah, the lip, right? We've got squamous mucosa on the inner surface, and look at that. This is really really, I have to point it out, I'm sorry. Look at that incredible example of a salivary duct with a double layer of columnar lining, one of the few places in the body you see that. And you can even track it down and look what it does. You can see it connect up to the minor salivary gland. Isn't that amazing? Wow. Normal histology
cool.
is so cool. If you're not blown away by that, I can't please you. Okay, there's nothing. That's just amazing. What a cut. Perfect. So yeah, there's our glycogenated squamous mucosa, minor salivary glands, the muscle, the skeletal muscle of the lip. What an incredible view of normal histology. And then out here on the cutaneous lip, in an old sun-damaged person, we've got this thing.
Yeah, and then the squamous proliferation, very well differentiated, but like glassy.
Yep.
Has some kind of cystic areas, and then the center, like crateriform part. So could be kind of a keratoacanthoma.
Yeah, very good. Keratoacanthoma, crater filled with keratin, glassy, like you said. Sometimes, I think this one shows that sometimes you get entrapment of elastic fibers, like the tumor wraps around them. You can also see that in reactive squamous things. And then there's all debate over whether you call it keratoacanthoma or keratoacanthoma type. And I don't know the story of this case. It's from a study set. Some people might be disturbed by the large excision here, but some people treat these more aggressively and surgically. Other people sometimes try more conservative methods. It just depends on the school of thought and also the clinical scenario. But for our sake, we have a very nice full specimen of this and a good example of some normal histology at the same time. So good job, Ellen. Keratoacanthoma. And I've got a whole video about keratoacanthoma I'll link down below. Okay. This is case 18.
So this looks like another pink bowl.
And you can just tell me the diagnosis since I've talked too much and made us run almost out of time. So we'll kind of skip through them quickly. What do you think it is?
A schwannoma?
Yeah, schwannoma. Hypercellular Antony A, hypocellular Antony B, and this one's more classic. Loose, kind of edematous or myxoid at the periphery here. Nice palisading and verrucae bodies in there. The cytology is not real clear on this particular example. This one did have one thing I wanted to show you. There. Smudgy pink around the vessel wall. That's hyalinization of vessels. That is a very characteristic feature that is usually present in schwannoma. So if you're thinking about schwannoma, go look at the vessels. And also, this helps you in cases where you don't have verrucae bodies. You'll need to be able to recognize the vessel changes and the other changes when you don't have good obvious palisading. It can be difficult. And this one also had some scattered pleomorphism. I can't remember where it was. Sometimes if there's a bunch of that, people refer to it as ancient change. Totally benign finding. There you go. Scattered pleomorphism is common in schwannoma. And in fact, you can see it in pretty much all nerve sheath tumors, really. Scattered big hyperchromatic cells is basically a normal benign finding that can be seen in schwannoma and in a variety of other nerve tumors. And here's more of that hyalinizing and hemorrhage around vessels, typical of schwannoma, and nice, sharply circumscribed and encapsulated. Very good. Okay, 20. Okay.
I'll just say real quick, I thought this was just a BCC.
Yes, good.
Yeah.
It is a BCC. It looks like basal, but it's a lot more pale, right? You get nice clefts and all the stuff you want for basal cell. But look how pale and pink the cytoplasm is. And if it comes into focus, we'll see. So granular, huh? So this is just a granular cell variant of basal. Basal has a lot of variants. Sometimes it can have very pale, grainy looking cells, vacuolated cells. And if you just had a little chunk of this, you could really struggle with making the diagnosis. But usually it's not hard to tell because you've got obvious nests and clefting from the stroma and peripheral palisading and all the other stuff that you like for basal cell carcinoma. It's just kind of a curiosity microscopically. But if you had a small piece like this and you couldn't see any of those things, then you could, just like with any small biopsy, you could struggle to tell. But otherwise, the features are made by the background that looks like other things of basal. And oftentimes there's normal basal cell component next to the granular areas. Good job. Granular cell variant of basal cell carcinoma. Ah, nice. Case 20. What's that?
Acquired digital fibrokeratoma.
Yeah, perfect. Acquired digital fibrokeratoma, a polyp, kind of a sessile polyp on acral surface real thick corneal layer over top, a lot of acanthosis oftentimes. And then the dermis is not normal, but it's very collagenous, very dense collagen, often with some dilated vessels. I feel that periungual fibromas or angiofibromas that you see adjacent to the nail in tuberous sclerosis, to my eye, look quite similar actually to acquired digital fiber keratoma. So really it's the clinical scenario that's the main thing to me that helps sort those out. Usually patients that have those, also known as Cohen tumors, have, that's one of the later features, cutaneous features of tuberous sclerosis. So usually patients with that will already have known tuberous sclerosis because of the other features of the disease that show up earlier. So I don't worry too much about missing that because it's not going to be like the sentinel feature. But to my eye, from the occasional cases I've seen of periungual fibroma or Cohen tumor, they look very similar to me to acquired digital fiber keratoma. And these are usually on the digits, but I've occasionally seen them like on the heel or the palm, other places. So on those, sometimes I'll just say acral fibrokeratoma. Benign. All right. Next is case 21. Eventually, down here somewhere. There it is.
I'll just say quickly, I thought this one was a granular cell tumor with a PEH.
Yes, good. And where do you think we are anatomically?
Tongue.
Yes, this is tongue. We have mucosa here with glycogen, squamous mucosa, and right under it, if we ignore the tumor, a solid mass of skeletal muscle. So that's usually going to be tongue when you have a whole, when what would normally be the dermis or the submucosa is replaced by skeletal muscle, and you got squamous mucosa on top, usually that's the tongue. And then this is a great example. If you go down here, classic, obvious granular cell tumor, lots of the pustulo-ovoid bodies, these little blobs of cytoplasm with a space around them. So if you like that, there it is, pustulo-ovoid bodies. At the periphery, you see that trickling, what looks kind of infiltrative of the tumor, making kind of trabeculae that push in between the skeletal muscle, just like it does with dermal collagen. Does the same thing when granular cell tumor interfaces with skeletal muscle. It just merges between. That's totally normal and, in fact, an expected classic finding to me. The really important thing here is this. Wow, that looks like squamous cell carcinoma, doesn't it? So in the oral pathology especially, this can happen in the skin some, but I feel like the best examples I've seen, this is reactive squamous pseudoepitheliomatous hyperplasia or pseudocarcinomatous hyperplasia. Reactive squamous epithelium that's mimicking squamous cell carcinoma, and it can happen in a variety of settings, as you guys know, but granular cell tumor tends to induce this. I feel like I see it more in mucosal sites than in skin. And the key here is on a small biopsy, you could say, oh, that's squame. So the key is if you think you're going to make a diagnosis of squamous cell carcinoma in the oral mucosa or other mucosal site especially, look between the squamous islands at the dermis or submucosa and see if you find any granular cells. And if you do, stop and don't call it cancer. Think about calling it granular cell tumor because it's almost certainly in that case going to be a granular cell tumor with reactive squamous change. And that way you avoid getting someone, a hemiglossectomy or something real significant and serious like that. So it can be really dramatic sometimes, the changes. And I've seen one in the skin that like mimicked a verruca, like on the foot. It was a big granular cell tumor and it made a very verrucous look on the surface. And in fact, on an original shave biopsy, I thought it was a verruca. And in retrospect, there was one tiny little focus of granular cell tumor there. And it was only when they went back and took a bigger biopsy that I was able to recognize it. So this is a really good example of granular cell tumor mimicking squamous cell carcinoma because of the pseudoepitheliomatous hyperplasia. Good work. Okay, next is 22.
This one looked like a plexiform.
Neurofibroma. Yes, and you know what? It does, because you've got these big islands of irregular size that you would imagine snake together. But if you ignore those and look at the rest, all the stuff in between these big islands and nodules actually looks like diffuse neurofibroma. So I find this often happens in NF1 patients where you have a combination of plexiform and diffuse neurofibroma mixed together and mingled. So that's, to me, a pretty common feature to see. And I have a whole video about neurofibromas and neurofibromatosis, but remember, to call something plexiform neurofibroma, you are giving the patient, essentially giving them a diagnosis of NF1, which comes with, genetic counseling and family planning decision conflicts and the decision about whether or not to have kids because of a 50% chance of passing on the gene and a lifelong risk of developing malignant peripheral nerve sheath tumor. So it's even though plexiform neurofibromas are benign, it's a very serious diagnosis to give someone because of the genetic implications. So I never make that diagnosis unless I have a gross bag of worms appearance. So here, I would tell them if they didn't have known neurofibromatosis, I would say, well, this has features very concerning for plexiform neurofibroma and diffuse, and you need to work the patient up to see if they have NF1, and they probably would in this case, but I won't label it definitively as a plexiform NF unless I can see it's truly grossly plexiform or the patient has known neurofibromatosis. That's my rule that I learned from Dr. Weiss, basically, and I think that's really valuable because of the real significance of what happens to those patients. And occasionally, because you can have multinodular nerve sheath tumors of other sorts, like plexiform palisaded encapsulated neuroma or plexiform schwannoma, that look plexiform microscopically but are not grossly. And if you mistake those for a plexiform neurofibroma, it can lead to a patient getting an inappropriate and incorrect diagnosis of NF1. And if you look at these islands, these plexiform islands, what they look like is in the middle, they're like filled with neurofibroma. They're kind of like sausages filled with a neurofibroma filling, or cannolis if you like. Whatever you like. So they're basically, these used to be nerves and they've been filled up and expanded by neurofibroma and then distorted into weird shapes and twisted around. That's what basically happens to form the plexiform neurofibroma. And most of the time, plexiform NFs, the classic ones, are deeper down, subcutaneous or deep soft tissue, the real big ones, okay? But this is an example of a diffuse and plexiform in a patient with neurofibromatosis 1. Okay, we're almost done. 23.
This looks like a palisaded encapsulated neuroma.
Yes, we're in the dermis, and we've got a spindled lesion that looks neural because it's got very nice palisades, right? Once we get focused, look at that nice palisading, almost like Verricae bodies. But like I told you, if you're in the dermis and you think it's a schwannoma, your first, second, and third choice should actually be palisaded encapsulated neuroma, also known as solitary circumscribed neuroma. That's the other name for this entity. And they often occur on the face, but I've seen them in a variety of sites, particularly the other place I see them is in acral surfaces. And the key to me is that they make these nice kind of bundles or fascicles, and the fascicles have these nice clefts around them, okay? So they have clefting artifacts that divide the bundles from one another. And the palisading is sometimes real nice like this, but other times it's much more subtle. So it is a bit different than the palisading of schwannoma in some cases, but they do have a lot of overlapping features. But those clefts, those cracks in between the fascicles, to me, that's the key. And see, this one's almost beginning to look a little plexiform or multinodular. And in fact, kind of an unusual thing that's been described not that long ago is if you have a plexiform palisaded encapsulated neuroma on an acral site, that is a sign of potentially Cowden syndrome. So I've only seen that a couple times, and I actually would suspect that possibility here, depending on the age of the patient. So when I see that, a plexiform pen on the acral sites, I'll actually mention and cite that paper from the literature. It was from a few years back, and let them know that they may want to, if it's a kid, make sure that they don't have other signs that would suggest Cowden syndrome. All right, and then finally, a really nice one to finish off for the day. Okay, what do you think this is? Here, I'll just go straight to the...
Yeah, I thought it was a JXG with those two-ton giant cells.
Oh, it's fantastic. Look at that. And two-ton giant cells are a ring of nuclei, and they've got a pink, smudgy, creamy filling and a crunchy, bubbly, foamy shell on the outside, like a little piece of candy, like an M&M. It's like my fourth trademark I've mentioned in this video. And then sometimes, though, they're not so well formed. Sometimes, that's a two-ton giant cell also. But it's kind of squished and cut at an angle. So learning to recognize little cluster of nuclei with foam around them, you're probably dealing with a two-ton giant cell. And in juvenile xanthid granuloma, classically, we see histiocytes, two-ton giant cells, and eosinophils. But those can all be present in varying numbers. There's some nice EOs, EO, very nice. But some cases lack EOs or have very few. Some cases lack two-tons or have very few. I think I told you guys all this last week, if I recall, because I think we had a JXG. But this is really a nice one. But yeah, look, you might get this and not think immediately of xanthogranuloma because you don't really see good two-ton giant cells. So if I start seeing histiocytes with some foam and then some EOs, and then I say, ooh, that's kind of like a little baby two-ton, then it's going to be a JXG. And of course, more common in children, but also can occur in adults. So the other name you can give it is a solitary xanthogranuloma, and it's totally fine to have them in adulthood also. But look, we'll end on that picture because who doesn't love a good Teuton giant cell? All right, thanks guys. Enjoy your Friday and have a great weekend. And everyone at home, thanks for watching.